Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome back to the Concussion Corner Podcast. My name is Dr. Jessica Schwartz, and in part 2 of our conversation with Dr. Julia Treleaven, we're going beyond the basics of cervical spine assessment and diving into what really moves the needle in post-concussion rehab. Today, we'll explore how fear avoidance and chronic sensory motor deficits can complicate recovery, and what the research is telling us about best practices for targeted intervention. We'll also hear Dr. Treleaven reflect on her time with our students at Concussion Corner Academy and what gives her hope for the future of interdisciplinary concussion care. If you're working with patients who just aren't progressing, or if you're looking to fine-tune your neck and sensory motor strategies, this episode is for you. Welcome to our Teach One, Serve Many community. Let's begin. Dr. Treleaven, welcome back to Concussion Corner.
Thanks, Jess. Thanks for having me back.
And just so we hop right into it, we just kind of finished on kind of talking about the caliber of students that are coming through Concussion Corner Academy and how much you're learning from them reciprocally, which is really so nice to see someone who's doing the research really be able to kind of cherry pick these questions from our students and hopefully inspire some future research. I know you have over 150 published research articles, so that's hopefully we'll see some future ideas and thought processes coming out from these conversations that go back and forth. In terms of education, though, to kind of stay in that lane, what are you seeing? For me in the early 2000s, not to age myself, my concussion education was one paragraph in a neurological textbook that was 1,500 pages long. And I had one small paragraph about yay big. What are you seeing in terms of how the concussion education from an entry level or master's or doctoral level programming is happening in your unis?
Yeah, so I totally agree. Really, there was very minimal talk about concussion. In fact, it wasn't even really recognized that concussion could be rehabilitated for only really in the past kind of 10 years or so. So in terms of our undergraduates, they certainly get information about the systems, so the vestibular ocular system and the cervical and sensory motor, but briefly and not probably put together completely in the concussion space. But we certainly, once they get to the master's level of musculoskeletal and sports, then we do a lot more in terms of bringing that information together with them. But, again, it's still probably something that they do need to seek out a particular course, postgraduate course that's directly related to concussion, because they might get a couple of hours or so on it.
Yeah, it's so interesting because we've had folks that are like 0 to 39 years out, PhD level physios and physicians and things like that coming through our doors. And it's so interesting to see really just to meet the clinician where they are, depending on if they're super novice and they've never seen a concussion patient, or they're a little bit more advanced and they're really trying to refine that cervical spine, ocular motor vestibular training that they want to really hone in on. So it's been neat. Just to remind our listeners, 2008 was the first year in the international consensus statement that we actually said that we're not going to be grading concussion. So there's no mild or severe concussion. We stopped doing that. You'll always see me on some kind of social media platform watching Grey's Anatomy, just yelling at the writers of stop grading concussion, up until a year or two ago. I'm on the social medias. It's the only time you'll see me yelling, unless it's for civil rights or something like that. And then 2012 was, again, why Dr. Treleaven is here, that first formal year that in 2012, the international consensus statement included the cervical spine. If we think about that, really making sure that we're connecting that the injury of concussion is both a central and a peripheral injury, and how that affects our patients functionally is so important to make sure that we're relieving our patients. And then again, as Dr. Treleaven said, 2017 was that first year that we actually called the injury of concussion rehabilitative. But remembering our history as physios in the United States, we turned 100 years old as a profession from rehabilitative aids in 2021. Ironically, at that time, 100 years prior, we were in the trenches, in a war, in a pandemic, ironically. But again, just connecting to that, our severe brain injury, our TBI patients, that we get them up in the ICU and we're walking them and we're moving them. And we've been, in absence of evidence, we often, take movement away from our patients. We've learned that from multiple sclerosis. We've learned that from cancer. Exercise is medicine. So it's so important to keep people active and moving. So again, just to kind of connect to a little bit of the history. So thanks for letting me do that, Dr. Treleaven.
It's okay.
All right. So with that being said, and we kind of have these kind of pieces of information, we think about high ankle sprains or ACL injuries and how long that can take, and 6, 9, and 12 plus months to really recover fully from some of these injuries. What are realistic timelines for recovery when the cervical spine is the main driver of persistent post-concussive symptoms? What are you seeing in terms of having to advocate for your patients, either with third-party payers or having jobs or teams believe the patient, is needing this extra time to recover?
Yeah, so it is difficult. And I guess it's a lot of the time we're coming against system barriers, right? So, and that's something that I went to a symposium the other day on whiplash, and it was really lovely to see that there was a lot of discussion about how to change systems. And there was a fellow doing a research project as a physio with an insurance company. And so they were trying to educate the insurers, and it was really great to see, because a lot of the time it is about that system-based level that you're coming up against. I think we also have problems here in Australia where traditionally sometimes people have been seen 2 or 3 times a week very early on. And so then they've already had like 20 treatments, but they're not better. And so then when you ask for another, say, 10 treatments over 6 months, then, you get a bit of pushback. So I think it's important, as from our perspective as well, to kind of realize it's a bit of a long game. And if you think about the ACLs, it's kind of the same. So you might see them a little bit early on while they're having, that sort of significant pathology and inflammation and those sorts of things. But then try and spread your treatments out, because it does take time to get motor control and a bit of a sensory motor control. And then certainly when you're trying to build strength and endurance, that takes time. So I think it's important that we spread the treatments out. So you might still see the patient the same number of treatments, but you might see them over 12 months. And I think that's something that we need to, be aware of. And a lot of time you can follow people up, on email and things if they have a problem, rather than having to see them as an official appointment.
Fantastic. And, there's always this controversy of manual therapy and physical therapy, and it really, kind of got poo-pooed for so long. And I just honestly unnecessarily so in my mind. But again, we're not doing just one thing, right? We're making sure that we're using all the tools in our toolbox to set our patients up for success, and just to make sure that we're proprioceptively, helping them, guide them, and maybe recenter them, or trying to facilitate taking them, out of this on block posturing that we see so often with the fear avoidance of just having neck pain and so on and so forth. So in terms of what role does manual therapy play in your treatment model? When is it helpful? When should we rely more on active rehab? And, kind of what are you seeing with that interplay in your both clinician and scientist role?
Yeah, so I think in terms of the evidence is that a multimodal approach is what works better, and that inclusive of manual therapy and exercise. And so I think, we need to be mindful of that it's not just manual therapy or just exercise. We do get a much better outcome if we combine the two. And actually, I was involved in a study that was done in Thailand where they actually added sensory motor training. So they had manual therapy and exercise, and they added sensory motor training. And they had 4 groups. One just had manual therapy and exercise. One had joint position area training, one had balance training as well, and one had both. And all the groups improved, but the ones who had the additional sensory motor had a better outcome and a better long-term outcome. So I think, we've now got some evidence to say that, that it needs to be even broader than just neuromotor control, and adding that sensory motor is really important. So I think in terms of manual therapy, I do tend to use it quite a lot as part of my treatment, but definitely not in isolation. Times when you may not use it more when the patient has lots of hypersensitivity, for example. And so, any kind of hands-on treatment tends to stir them up. And so then, there's no point in doing that. But certainly if patients can feel that they're getting improved movement, and then you can back that up with an exercise that they can do at home to maintain that, then, you get better buy-in from your patients if you don't do manual therapy and just give them an exercise, for example. I think it's times when you may not do it, times when you probably definitely should do it to get better buy-in. Let's think about what the patients also are expecting and wanting as well, because that does affect the outcome.
I'm so used to having such high level conversations with you. So I just want to make sure that I'm actually thinking like now that this actually may be the first time somebody might be hearing of that term sensory motor exercises and how that's different than the kind of like the world's like mind's eye of what physical therapy treatment actively looks like in terms of rehab. What are some examples of some sensory motor exercises that you use in your practice and in your research, just so you can kind of explain visually for folks that might be visual learners or have never seen or heard of these sensory motor exercises for the cervical spine, whiplash, and concussion patients?
Yep. So we have about 4 different domains of exercises, I guess. And so one is sort of head movement control. So we have joint position error. So being able to relocate the head back to neutral, particularly with the eyes closed, being able to really finely move the neck in a very finely coordinated way, tracing a pattern or following a pattern. Then we have ocular motor control, so gaze stability, but with the neck, it's much more in that sort of slower movements and being able to maintain focus as you slowly move the neck. Eye-head coordination, so being able to move your eyes independently of the head, and trunk head coordination. So patients often are not able to keep the head still while they move the trunk, and they move like as an en bloc. So that's an important exercise. And then you have balance and postural stability. So it might be doing things like particularly taking vision out of the equation. So things like balancing with the eyes closed, but then also walking with head movements. So large range head movements and those sorts of things. And those exercises can be, have shown to be effective on their own. But we know that most things are effective in isolation, but when you combine them, you get a much better outcome. So they're really important.
Yeah, fantastic. And, I think it's so important to kind of just discuss, like, that's the difference between that novice clinician and that more seasoned clinician that's really able to put together that comprehensive targeted physical examination from either a screening standpoint or really something more comprehensive and detailed, and then being able to tease out the functional deficits of what the patient is describing to you subjectively, and then putting that to work in the clinic. And it's just been such a just wonderful to see these high level conversations happen, in your programming at Concussion Corner. So just, I hope that lights you up inside as much as it does to myself, just because we just had a student come and take off a half a day of work to meet me in Milwaukee, Wisconsin, and she actually met Dr. Tina Master walking out as she was going to a museum for the last hour it was open. And it really brought me, goosebumps, because the two of them had a conversation that was so high level in the middle of a hotel lobby while walking, trying to get out of the hotel. It was so casual. It was like the top probably 0.5% conversation you can have in a concussion way. And it was so natural. It was so enthusiastic. And it just brought me so much joy and hope to know that we can serve this patient population in such a great way. And I just wanted to thank you for also contributing to that so that these conversations can be had all over the world.
Thank you.
As we, prepare to wrap up our last few minutes here, I wanted to talk about fear avoidance and catastrophizing. We see it with our whiplash associated patients. You've been doing the research for years with Michelle Sterling and all those phenomenal humans out in Australia, but really talking about fear avoidance and catastrophizing as it pertains to the concussion patient with the cervical spine dysfunction. So what are you seeing in terms of either patient presentation, things that might be missed from other providers, and just kind of just overall that 360, making sure that we're addressing that fear avoidance component, which can also include even cognophobia as well, which we touch on. But what are your thoughts there?
Yeah, so I think first of all, we have to sort of say that, even though it's sort of brought out in the literature, catastrophizing and fear and things like that, it's not in a high percentage of patients with neck pain and indeed with whiplash. Okay, so when you look at the research, often it might be a predictor of a poorer outcome, but when you actually look at the range of scores, often people are well below normal. Okay, and I think in terms of fear of movement, it's probably a normal kind of thing. You'd be pretty silly to be, running on a terribly sprained ankle, so I think we need to kind of recognize that not everybody's got it, and we should be looking for in the people who definitely have it. And then there are those people who do. And so they will be the people that, really are just, walking, there's no natural movement. They're, just locking in. When they go to turn, they're just really, and then they're telling you that they're worried about doing any kind of exercises and those sorts of things. So I think for those, it's about the education. We can definitely have good education on that they're not going to re-injure themselves and those sorts of things, giving them good guidelines on, what to expect with exercises, what level of pain exacerbation, for example, when that should reduce, how to manage it, those sorts of things, so that patients are not concerned if they have a bit of a flare-up, they know how to manage it, that sort of thing. What exercises do you stop doing if you do get a flare-up and go back to these ones? And so then people are much better at managing it and they don't tend to be so concerned. The sensory motor control training can be really good for this sort of thing because they get that external feedback. It's getting them to do things like keep their head still and move the trunk, and move their eyes and keep their head still, and then move their head and keep their eyes still. So things like that. So I think that can be really helpful. And then you can also do things like, velocity training. So, but get in a safe way so that you're practicing going to the range that they know is pain-free, and then they're practicing doing that more quickly. So I think we have a role to play in that education piece, and then also making sure that we're providing exercises that are very graded. It's the same thing that we do with our cognitive and exercises. We're sort of grading people, setting them up for success, and then making sure that we're increasing that so that they're getting benefits over time.
I just find, even for myself, like I'll just try to disassociate them. I find that they're more fear avoidant if they've the higher healthcare professionals they've seen prior to me. So on average, folks see between 6 and 8 providers before they get to me. I have a very small practice. It's very boutique. I'm doing running the academy mostly now, but I do take, word of mouth referrals and things like that. And again, that's on average for 6 to 8 years, 6 to 8 providers. And that's when I see the fear avoidance of just they've had misinformation, or it took them 3 months to get into a provider that didn't spend time with them, and then they're just overall sensory guarded. So for me, even, keeping your work, literally, we had your work in my residency when we were the first 6 residents at NYU in orthopedics. And, I'm reading all of your articles when we're in our cervical spine section with Bob Rowe, who came in from Florida to do our cervical spine section. And again, I actually will take the laser, and I'll actually, if they're really having neck guarding, I'll put the laser on their arm. And I'm like, okay, so let's start to track things here. Let's start to turn, let's put the laser, let's turn your head, follow, and so they can follow on their own. And it's just kind of being able to adapt and adjust. And again, believing your patient. We have to validate the patient symptom profile, and we have to believe our patients at the end of the day. And if they're afraid to turn their head one way, we have to work and get creative around that. So it's been very neat to be able to incorporate those sensory motor activities while being able to educate the patient that the old adage of like sore is safe, and also that you're not causing any more damage to your original injury, and that we just need to make sure that your symptoms recover. So if it took us half an hour to recover last time, or 3 minutes, let's try to cut this down and recover in 30 seconds next time between each, rep or set. So it's just very neat to see getting to put this all together from a functional standpoint, from a patient-provider standpoint.
And now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show.
Yeah. Definitely.
So Roger Carey reached out and was like, I have this idea, and can you write the concussion chapter of a textbook that I'm doing with Barbara Cagney and Roger Carey and all these lovely humans? And you were in the book chapter realm. I'd love to hear about what are the 2 chapters that you worked on, and then I also want to cover the research article that you're going to be publishing shortly.
So I was involved in cervical-related dizziness. So Dr. Lucy Thomas and I contributed to that section. And so it was really good because we really tried to delve into BBI and proprioceptive dizziness, and then potentially the different types of cervical proprioceptive dizziness, and then a little bit on the autonomic as well, which is starting to come out a little bit more in the literature. And then we did a case study chapter, and we included Sue Reed on that. And so we tried to incorporate cases that sort of delve into all of those different things. So I think it'll be a really good chapter, and I hope that people find it really useful to help tease out, these neck-related causes of dizziness, but obviously, they're very different and they need to be managed very differently.
Yes, and the book is called The Head and Neck Theory and Practice. It'll be out in the fall of 2025, and I think pre-orders can happen in August of 2025. So I'm really looking forward to seeing how that gets used, and hopefully will be used in probably universities all over the world. So I'm excited to see that get published. And finally, a new article is coming down the pipe for you. So I'd love if you can break that down for our listeners and just talk about the salient points and why it was so important to include the objective measures that you did, and kind of your thought process to, hopefully get the outcomes that you got in this research article.
Yeah, so this was a reanalysis of my PhD student, Olivia Galea, who's now working in New Zealand. So she did a really big assessment on people with concussion. She had a group of people who healthy controls. She had a group of people who said they were recovered, and then she had a group that still had persistent symptoms. So we looked specifically at that group, and we published 3 articles. There was one article that looked into the cervical spine measures in those patients, another that looked at the vestibular ocular, and another that looked at the physiological and the results of the Buffalo concussion treadmill test. So what we did with this article was we tried to put it together more from a clinical perspective, because often articles tend to sort of say, people have increased muscle strength, decreased muscle strength, or decreased endurance. Let's put it together as a system, because people don't have things in isolation. If you've got a neck disorder, then you generally have altered joint dysfunction, muscle dysfunction, range of motion and kinematic dysfunction, plus or minus sensory motor deficits. And so we wanted to put that together. And then similarly with vestibular, we wanted them to have at least 2 vestibular ocular, not just one isolated one. So what we found, which was the most interesting, was that 85% of those people had a neck disorder. So that meant that they had to have 3 positive tests, and by positive, that was judged by them being over the 95% confidence interval of the healthy individuals that were in that study. So 3 out of the 7 tests had to be abnormal, and that included 2 musculoskeletal, so that was either joint dysfunction or range of motion or velocity of motion or muscle function, and then or they could have some sensory motor as well. And a lot of them had 5 out of 7 abnormal. So that was really interesting. Then we had, but again, with that, we also found that a lot of people, about 30%, had all 3 systems. So they had the cervical, they had failed the Buffalo concussion treadmill test, and they had some 2 or more vestibular ocular. So just demonstrating that, we can't silo these concussion patients. We need to know enough to either manage each of those systems, or at least know when to have our kind of network of people that we can refer out to treat them. And the other thing I think that highlighted was, we didn't necessarily look at whether this was causing their symptoms or not. But if somebody's got a neck disorder and it's not managed, and 85% of these people did, then that's not setting them up if they're going to go back to sport. That could potentially cause, re-injury, or they could end up with having recurrent episodes of neck pain in the future if it's not addressed. So I think that's really important. And I think there was a systematic review done in 2022, which basically demonstrated that the neck is not even considered a lot in concussion assessment. So I think it really highlights the reason that we do need to look at the neck in these patients.
And this is exactly why we have the Concussion Corner podcast, Julia. We have this because I get to say we have to know what we're looking at so we know what we're looking for. And then I get to say that one line and sentence, and then you have done years of research on, I'm sure, that one paper. So, those are big numbers. Those are important numbers. Those are clinically meaningful and accessible objective measures and testing that we can do in clinic in reasonable amounts of time, and that are easy to impart as long as you have some training and some repetition and probably some guidance to do them, because that's all like postdoctoral, post-school learning often for a lot of that. But at the end of the day, I mean, that's functional, that's salient, and those are real numbers that we can try to replicate and try to reduce that 8 to 17 year white paper to clinical knowledge translation to actions. Just thank you so much for doing the work. As we wrap up here, and also, where can we find the article? Where would that be published?
So that'll be in Musculoskeletal Science and Practice.
Fantastic. And we'll make sure to put all those links in when everything's published.
And it'll be open access because our university has an agreement with Elsevier. So that's good.
Fantastic. All right. As we wrap up here, are you going to be teaching anywhere or anything else to look forward down the pipe with any of your research and or teachings?
So I'm going to a conference in New Zealand in September in Queenstown. So that should be quite nice, and doing a course there as well. And then there's the Australian Physiotherapy Association conference, and that's going to be in October this year. So that'll be really nice to catch up with all the research and what's going on. And I'm doing a kind of symposium thing with some neurophysios. So we're trying to bring that together to the concussion with the neck and the vestibular ocular. So that should be really good.
Fantastic. And I also have to add, if you'd like to meet Dr. Treleaven as well, virtually, internationally, anywhere in the world, she'll also be live with us in our fall cohort at Concussion Corner. So you'll actually get to meet all of our faculty, and we'll get to spend 2 lovely hours with her on a live Q&A. So I can't wait to see you again in the fall and with our lovely students. And any imparting words as we head out for folks that are wanting to learn more about the cervical spine and get connected with their concussion patients internationally?
Yeah, I think, just always remember, don't forget the neck. I think that's important. And if you feel that you're not upskilled enough, then try and reach out and get some upskilling with the appropriate courses and things. And then just even so that you can recognize when the neck is involved. And if you're not competent for treatment, then you can refer people out. So I think, but being able to identify it is going to be important.
Thank you so much for being a part of this Teach One, Serve Many community, Dr. Treleaven, and we will hopefully see you live in the fall. Take care.
Thanks, Jess. Really happy to be here.
Thanks again for spending time with us on the Concussion Corner podcast. We are so grateful to Dr. Julia Treleaven for her expertise, humility, and the immense value she brings to our global concussion community. If this conversation sparked new ideas for your practice, now is the perfect time to join us for our upcoming fall 2025 cohort of Concussion, the Patient Rehabilitation Journey, Part 1 and Part 2. This is your opportunity to learn directly from Dr. Treleaven and our entire faculty live and online inside of a supportive interdisciplinary learning environment. Enrollment is now open. Head over to concussioncorner.org to reserve your place and become a part of our next generation of concussion care champions. Until next time, thank you so much for being a part of our Teach One, Serve Many community, and we'll see you next time. Take care.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.